So we can start dissection. Okay, perfect. Start with an eyelid incision. Superior eyelid incision. Is for transmission on streaming, in streaming. Sì. Sì, delle pinze. Non c'è niente ovviamente qua, però there is nothing here. But we'll try little by little. So start with subcutaneous dissection. Sparing the levator palpebrae. Devo farlo uscire. Perfect. Fine, thank you. We are starting the skin phase. Yeah. Starting the skin phase and the subcutaneous dissection. This is a cadaver a little bit hard to dissect. So we will make a longer skin incision. So we have to fill the orbital rim. Try to detach the subcutaneous tissue that is very hard to dissect. Filling the orbital rim underneath. So you can see orbital septum, the lacrimal gland, and the orbital rim. And we are exposing and dissecting the periosteum of the lateral orbital rim. Cutting the periosteum in order to detach it from the lateral orbital rim. So we are looking for a plane, a subperiosteal plane inside the orbit to tailor I have to enlarge the incision due to the rigidity of the cadaver. We are progressing little by little, trying to find the right place to tailor the transorbital corridor. So we are seeing the lateral orbital rim, the superior orbital rim, looking for the frontal zygomatic suture. So we are exposing the lateral orbital rim little by little. Okay. Okay, perfect. So we have to replace the retractor in order to better displace eyelid. Okay, perfect. Lacrimal gland, and we are trying to get into the orbit from there. We try to get into the orbit from there, but we need probably to get to the frontal zygomatic fissure before entering. Okay, this is the temporalis muscle inside the temporal fossa from the external cranial surface. We will see it after drilling the proximal portion of the lateral orbital wall. We may need just some more space to get down to see better the lateral orbital rim. Parlando. I'm talking you. Okay. So lateral orbital rim is being exposed progressively. Okay. Okay, now we'll try to gain an access, a transorbital access using a subperiosteal route. Okay. Retracting the orbit is very, very hard because this cadaver is very rigid, but we are trying to build our triangle to get into the orbit. Okay, so we build our triangle to start dissection. And we'll try to find a superiosteal way to dissect the lateral orbital wall. Volentieri, se vuoi darmi una mano. So we are trying to build an orbital corridor despite the rigidity of the cadaveric specimen. Uh-huh. So we are built the triangle we told you before using this superolateral axis, so both superior and lateral orbital rim, frontozygomatic suture you can be see here. This one. Ok. Sì. And now we are trying to get the orbital access. So on the lateral side of the orbital wall, the most important thing is to be subperiosteal in order to expose all the lateral orbital wall. Now we are trying to get some space because the cadaver is extremely rigid, and try to show you how long you can go using the exoscopic visualization. So see, you can really go in the depth seeing the lateral wall, and drilling with exoscope in the first steps is more comfortable because you don't have the endoscopic tip. Your tip is not hindered by the other instruments. You don't need to clean your endoscope little by little, progressing the dissection. No, we have it, a malleable spatule, but it will never be as good as this, because you need a lot of force to do. Push more on the orbit to gain some space. Ok, ma devi mettere a fuoco, you need to focus. Ok. Stai attento che si sente in streaming quello che dici. Ok. So perfect. Now start drilling. Start drilling if we are able to find just some more space here. Ok. No. È fissato, it's fixed. I'm commenting the cadaver is rigid, so we are trying to build a triangle. And then we will progress with the endoscope probably. We need some water and searing. Let's ask someone. Mm? I think we have to start with endoscope. C'ho la mano.
Better retract this, you have to continue to perform a lateral cantotomy, more down, because otherwise it will be impossible to detach.
Lateral cantotomy.
Yeah, perform. It's not already done. More down, more down.
Okay. No, no, no. No, no, let's do a little pause in the audio. Oh. La cosa più importante è fare questo. Esatto. Lacrimal gland. Ok. I see it. Vedi? Non va bene perché si vedono le mie mani e non si devono vedere. Ah no, cosa va in onda è quello. Ah no, non ci interessa. L'ormai non ci interessa, l'ormai lo vedono loro, ma in onda va questo. Ok. Ok. No, voglio capire cosa tira. Se conviene mollare qua. Vediamo. Perché forse tira troppo. Ok. 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 Adesso montiamo l'endoscopio. Se riesci a farmi vedere bene là sotto con, no, con l'esoscopio. Devi tirare. Adesso ci facciamo una piccola, un po' di orbitotomia, che se no non ne usciamo. va bene, aspetta. Un po' di orbitotomia per avere un po' di spazio.
Ma continua a piegare verso il basso, cioè qua devi scollare, vedi? Fermati un attimo. Qua devi scollare, perché tu devi. Secondo me. No, ma qua, capito? Estenditi inferiormente. Perché sennò. No, qua.
Sì,
No, fai
sì.
solo. Togli questo. E poi ogni tanto. Qua devi andare. Perché sennò non lo riesci proprio a staccare. Piano piano, ti fermi. Non fare le solite cose. Devi staccare fino a vedere il.
Mhm.
Fino a vedere proprio. Adesso questo.
Ho sentito che qualcosa cedeva.
Infatti, adesso puoi retrarre molto meglio.
Mhm. Mhm.
Vai, sì, adesso lo mettiamo.
Sì.
Aspetta, prenditi un
Ah,
attimo.
la taglio adesso la ghiandola lacrimale.
Guarda, adesso c'è molto più facile. Perché tu devi far vedere proprio, vai, sì, devi far vedere proprio la.
Ok, cerca di andare più giù con questa. Ok. Ehm,
I want to the server to try if you agree.
ok, yes. Grazie. Adesso continuiamo, eh? Lo facciamo fino al... Come on, guys. Come on, guys. Take your gloves here. This is for retracting the orbit. This is dissecting. Then you can start, I start drilling the proximal portion. Just a little bit of orbital ring removal, because it's a huge orbital ring. And then start drilling to expose the temporal fossa, the first part of the lateral orbital ring. You can try it.
So this is at this point of the dissection. We are drilling out. It's very important to all the observer, please. It's very important that the first drilling. Stop 1 moment. It's very important that the first part of the drilling is very lateral. You don't have to go to the middle fossa at this point of the dissection. You have to expose the temporal muscle. So remember that the most important thing at the beginning is to expose the temporal fossa, not the middle fossa. Why? Because you have to gain space. If you start drilling here, if you drill medial, you will have the proximal corridor very, very small. I'm speaking about without osteotomy. If you are doing osteotomy, for sure you are going to expose the temporal fossa first. But if you are not doing lateral orbitotomy, and I suggest you in the first cases not to do, because it bleeds, it's not so easy, the skin incision is small, it's not so easy as it seems to do the lateral orbitotomy, in my opinion. Probably one idea, one compromise could be to do the out-fracture, the open door technique, because you just do 2 cuts and then you fracture. It's true, that's true. Yeah, but if you have, for example, a tumor that is near the is extradural, near the temporal pole, you don't need to open to do a lateral orbitotomy. If you have to go intradural, or if you have to go in direction of the anterior clinoid or anterior petrosectomy, for sure you need it. Yeah, but if you have to go here, deep in the middle fossa, just in the middle fossa, to expose the dura of the middle fossa, you don't need it. And if you don't do it, the lateral orbitotomy, you will approach the tumor in 30 minutes. In 30 minutes you will be on the lesions, because you only have to detach the periorbit, start drilling, and in 30 minutes you are on the lesion. Okay? Yolanda, do you understand? Do you see that we do the same in the operating room? See?
We are dissecting in the plane of the pretarsal plane. Do we always see the lacrimal gland?
No. Truly, this is the lacrimal. This one. Now Francesco already exposed. You see the distinction between, Francesco, show it us the temporal muscle and the temporal fossa. He's going here in the temporal fossa. This is the fibers of the temporal muscle. You see, Francesco is trying to dissect the temporal fossa. You have to drill a little bit more of bone, Francesco, because otherwise we cannot. You see this stone here? You have to completely drill out. Otherwise you cannot proceed your dissection medially and deeply. And as you can see, he already performed. Try not to put the hand over the surgical field. He already performed a lateral orbicantotomy. No, Francesco, wait. This way they don't see nothing if you drill. Ma dobbiamo. Qual è quello che viene da Giuseppe?
attivare. So we have exposed the temporal fossa in the proximal portion of the lateral orbital wall. We are now dissecting the temporalis muscle away. We are in the exocranial surface of the skull at the Pterion. And we are trying to gaining enough space to perform the lateral orbital wall drilling. So trying to find the right plane to keep drilling, and in few moments we probably need to pass to endoscopic visualization. Okay, so you can keep drilling this aspect of the bone. You see this one. Be careful not to injure the periorbital, and to go in this way. You see this one. Little by little, and with irrigation. Try to come.
then fat trapping all the time. I love fat trapping.
Yeah, that's why we have to do another article for it. I told you also. So remember for reconstruction.
You see, I can reach the temperatura, but before to do that, I want to have enough space for the section.
So in any Skullbase approach, you don't have to do the whole inside. You have to first think about the proximal corridor, enlarge the proximal corridor, and then you go inside.
I cannot move here. I cannot move for this. This is for example the endoscope outside. I cannot move for this. You see that? You see this part of the bone? You can drill it out. You have to drill it out.
You mean orbital ring?
No. You see the orbital ring is outside. I am flattening the inner part of the orbital ring. I will remove the orbital ring definitely at the end. But for the approach, it's very, very important to just like when you do the supraorbital, you flatten the orbital roof, just like the same. This part should be drilled down. And a few millimeters is very, very good.
However, we saw the technique that has been showed yesterday, the lacrimal keol, that Arlene first described, is a kind of flattening also of the lateral orbital ring.
Prova. 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 Prova, prova.
the temporal muscle here. I do not have the hook, but I will place the hook here to show the floor of the middle fossa over there. Then the pterion is over there, following the lesser spinal wing, and the petrosuffix will be in this direction after interlunar dissection, extralunar dissection of the cavernous sinus. If you see, I told you that the inferior orbital fissure marked the foramen rotundum, and this is correct. So you see that the retractor is placed at the level of the inferior orbital fissure, and this is where V2 we will see V2 when we open up the cavernous sinus. I don't know if you want me to stop and to show the participant. Yes.
Va bene, questo è un po' troppo alto, te lo abbasso. Ok, va bene. Mo facciamo così, usa presentazione. Ok, ci sei. Vai.
Okay. Hello to everyone.
Guys, just one moment of attention. Can you start?
Yeah.
Let's go.
Hello to everyone. I'm Amedeo Piazza. Today I have to talk about transorbital bone anatomy via photogrammetry. Before talking about before talking about the anatomy, I would like to explain what it is photogrammetry. And photogrammetry consists of a process scanning of a surface. So it's a lot of photos that will be connected, and after a 3D elaboration, we will create the 3D models. So with our group, we divided in 3 different steps in order to categorize and make it feasible also for neuroanatomy. So we created these 3 steps, that is overview, scanning, and close images. The overview is around 20 images that you have that you have to take from anterior to posterior and lateral to contralateral in order to have an overview images. Then it's important to take other photos to overlap at least at 70% all the surface during the scanning, and you have to take photos from 0 degree, plus 35 degree, and then minus 35 degrees. For the deep located structures, it is important to take at least 3 photos from every deep located structures. And with this new technique, this is the process, how we do the photos, and maybe is helpful. And taking all these photos, at the end, we can create these 3D models and bring that to the similar to the reality. And our results is this. So on the left side, this is the standard HDR images, and the right side in both panels are our 3D models. So now we are happy because we can have a quite good quality and reliable, especially for the bony anatomy. And we move forward, and we created also a dissectable 3D model of endoscopy dissection. So you can either use this model with a computer or with a VR goggle. It's still not published, and we hope it's going to be published soon. So now we have to move to the transorbital part, and my duty for this presentation is just to show the 3D anatomy and the perspective from intracranial part. So I divided this in 7 steps, not to remember all the book about 7 steps, but just because there are 7 steps. So the first step is we want to find the deep fascia of the temporal muscle. So you have to drill the lateral wall of the orbital rim, the lateral wall of the orbit, like we do here. Then we move to the second step that we just did on the cadaver. So we want to remove part of the sphenoidal wing and the greater sphenoidal wing in order to create these structures, that is the sagittal crest. And the sagittal crest, in my opinion, and like in every opinion, connect the superior and the inferior orbital fissure, and is a good and reliable landmark. In this way, we also expose the temporal dura, and if we go transcranially, this is our overview. So we can understand our future landmarks that are the foramen rotundum, the superior orbital fissure, and again the hole that we created for shows the middle fossa.
Can I say something?
Yeah, of course.
This way you fully understand that once you drill from lateral to medium, the remaining part near the superior orbital fissure, the remaining this piece of bone that is here. Sagittal crest is the ending part of the main orbital plane. And we can appreciate that because it's an artificial landmark. It's not a native landmark, as I told you yesterday. So only with these models, with 3D models, we can understand. Otherwise, when I first met Dosik, where is Dosik? Dosik told me, sagittal crest is not the part near the superior orbital fissure, it's the maxillary struct. You are wrong. Say, no, you are wrong. Because you don't use models, because the maxillary struct, please rotate, and I show you what is the maxillary struct. The maxillary struct is this bridge of bone over the foramen rotundum. It's this bridge of bone. Like the optic struct is a bridge of bone between the anterior clinoid and the sphenoid body. Struct means bridge, connecting bone. This is a connecting bone over the foramen rotundum. And this is the maxillary struct. This is the optic struct and this between the clinoid and the sphenoid body. So the sagittal crest is not the maxillary struct. It is a sagittal bone. There is the remaining part that you drill out once you expose the posterior belt. Okay.
So then we can move to the third step, and basically we expose also the frontal dura, and we left there the lesser sphenoidal wing. And is how Alberto says before, is it important in this way you can easily appreciate the optic canal and the anterior clinoid process and how is related also intracranially. Okay. So what we miss is just to remove in the next step the less sphenoidal wing that cover the sylvian fissure. So we don't have brain here, but if we could have, that's what we definitely will find. The first step, as I told you before, we are just removing the lesser sphenoidal wing, and we left there the anterior clinoid process, and we can see the relation between this structure and how we can go medially. Like here, again the maxillary struct and the anterior clinoid process. But to go really medially, so to see better the optic canal and the anterior clinoid process, we have to do the lateral orbitotomy that to us gain access in this way, so we can get up to 15 degrees in order to see better the intraconal and right behind the conal portion.
So Dosik, you see that the sagittal crest is not maxillary.
So if you want, also the drilling can go up to the pterion in order to enlarge our dissection and bony removal. If we look from inside, our approach is going becoming always bigger. The sixth step is just the removing of the anterior clinoid process, and we remove, of course, from the optic struct. But what for me is more important is the last step. So in the last step, we can arrive up to do an anterior petrosectomy. But if you are familiar with anterior petrosectomy transcranially, what is, in my opinion, is everything is tilted because we are going from anteriorly and not from laterally. So the carotid, if we see, the carotid tilted, and is important structure because the injury of carotid, of course, it's a lot of bleeding. So, that is how it changed. Non sta andando, non riesco a farlo andare, si blocca. Okay,
So you see
so,
that we follow
sorry.
just medial to the internal labus meatus. So So once you will go in the afternoon to the anterior petrosectomy, you have to find the GFPN, because the GFPN that is here gives you the leads. Otherwise, you can go too lateral or too inferior, there is the carotid canal, and you can even enter the internal submeatus or enter the horizontal segment of the metasteroidal. Okay, so if you're coming from ventrally, we don't know where is the carotid or the internal submeatus, which are the two risky points. And in this, you have to follow the GFPN, but we will see after.
So now,
Thank you. Amedeo is our 3D guy. He's very 3D also do when their sister has a baby, you know the 3D of the baby.
Qual era la tua? La mia, qua sotto. Aspetta, fammi chiudere questa così ce la togliamo. Qual era? La seconda. Questa? Cioè. Ah, ok. Aspetta, fammi vedere solo qua. Ok.
This would be connected. See. Yeah, we are adding model and model, but during the next time.
Okay. So, dear colleagues and friends, it's a pleasure to be here. Firstly, I've been asked to describe the step-by-step anatomy of endoscopic transorbital routes. But then we converted our presentation just to understand what are the key landmarks and the target areas when we are performing an endoscopic transorbital route. So I will try to be simple because anatomy is simple. So we just have to observe it and describe it. So I'm going to present some mine personal dissection and some dissection of Dr. Periselda during my research fellowship that I did in Mayo Clinic Rochester. So orbit is a conical space, a bony space that is very closed but can be used as both a corridor to assess the orbit and a corridor through the orbit to assess several intra and extracranial regions. And we can see this better in this superior view of this alcohol fixed specimen in which we have dissected the left side. In particular, the endoscopic endonasal trajectory, as you can see here, can very well expose the medial and inferior side of the orbit. The microsurgical transcranial view, the superior and lateral side. But with the orbit, we can assess the orbit or use the orbit as a corridor and assess several other intra and extracranial regions, so the cavernous sinus, all the middle cranial fossa, but also extracranial region, for example, infratemporal fossa. And this is the major important concept, neurosurgical concept of using the orbit. This is a frontal view. Amedeo have already explained all the bony anatomy. I would like just to stress some of the other just observation of the normal bony anatomy. So this is the supraorbital notch, is a very important landmark. We have seen it when we are performing an eyelid incision, a superior eyelid incision. The medial limit with the frontal bone, zygomatic bone, lacrimal bone, lamina papyracea. Here is the orbital process of the palatine bone, very important landmark too. In the superior limit, we have the frontal bone, maxilla inferiorly, and the facies orbitalis of the zygomatic bone, and the greater wing of the sphenoid bone on the lateral side with lesser wing and anterior cranial process. Here, the superior orbital fissure connecting with Meckel cave, our door to assess the cavernous sinus and Meckel cave from the orbit, inferior orbital fissure to the pterigopalatine fossa, optic canal, ethmoidal arteries. Now, let's start to build the approach to the orbit and then understand what are the connection of the orbit with other intra and extracranial region. This is a lateral view. This is a very important landmark. This is the orbicularis oculi. And why it's important? Because we have to assess, to pass through the orbit, and we have to understand the relationship of the soft tissue with other important structure. For example, we should know that 2 centimeters posterior to the orbicularis oculi, there is this branch. It is the frontal branch of the zygomatic division of the facial nerve that is important to know in order to avoid, when we are performing a lateral canthal extension, to not extend too much posteriorly in order to avoid to damage this branch. And this is a closer relationship of this anatomy that we are showing. If we proceed further with the dissection, now we can understand the relationship between the orbit and the temporal fossa. If we perform a lateral orbitotomy from outside, now we can clearly see how the periorbit is in close connection with the temporal fossa. We can assess the orbit if we want from outside. Here is the lateral rectus muscle, inferior rectus muscle, superior rectus muscle, elevator palpebrae, lacrimal gland, lacrimal nerve, optic nerve, superior ophthalmic vein, and we can describe all the anatomy. But what is really important about assessing the orbit is understanding the relationship of the lateral wall of the orbit, not only to this first extracranial window with the temporal fossa, but also with this intracranial window of the middle cranial fossa. And how we assess this? By drilling the greater sphenoid wing from lateral to medial, and if we want also we can start to drill, like we have done here, the temporal squama. And this is the concept seen from outside, so not inside the orbital. We are outside and we are understanding what we are doing. So this is the sagittal crest. The sagittal crest, now you can clearly see how is limiting you the view, the access to the cavernous sinus. If we remove this crest, that is not a true landmark, it's just something that you are building. It's not a real landmark that you can find in the real anatomy. It's something that you are building, just drilling from lateral to medial the greater wing. And if you remove this triangular shaped area that is left, what we can do, we can have a window that is direct to the cavernous sinus. The first nerve that we'll identify, and you will see in your dissection, will be V2 with foramen rotundum, and then by removing this sagittal crest, you can really start to perform the peeling of the lateral wall of the cavernous sinus and the interdural dissection. And you will see, remember this dissection, that you can open all the cavernous sinus. So you will identify V2, V3, V1, all the structure of the superior orbital fissure, trochlear nerve, moving from lateral to medial to the superior oblique muscle. Here you can see also the abducens nerve, moving from medial to lateral to the lateral rectus muscle. So when we are approaching the orbit, always keep in mind that there are the importance of tissue, functional soft tissue, so again the orbicularis oculi, superior tarsum, inferior tarsum, and the septum, but also in a deeper level.
Functional, the orbicularis.
Not functional, but at least you have to use it as a landmark to.
But we have to cut it. This is
Yeah,
important.
for sure. And so in a deeper level, you can identify the supraorbital nerve with the supraorbital notch. Here we have also the supratrochlear nerve, the trochlea, the infraorbital nerve, lateral canthus, medial canthus, so all the structure that you have to face with when you are approaching to the orbit. So this is a very important concept that I would like to summarize that has been exposed by Dr. Mo 2 days ago. So there are corridors through different quadrants of the orbit, and we can identify 4 quadrants and endoscopically assess following the anatomical landmarks with this endoscopic orbital approach. And this is the first quadrant that can be assessed by a superior eyelid incision, the medial quadrant with a transcaruncular approach, the inferior quadrant with an inferior conjunctival incision, and the lateral quadrant with a lateral canthotomy. But in real life, what is endoscopic transorbital surgery is what has been described by Dr. Sikong, so the union of these 2 corridors with the superior eyelid approach, so defined with the eyelid incision with or without the lateral extension, and we can also add this lateral orbitotomy to increase the lateral entry point of our surgical trajectory. So let's go very fast and let's concentrate with the superior eyelid approach. This is just the superior eyelid incision, all the soft tissue that we can identify. We need to find the superior orbital rim, and we are following this corridor limited medially by the ethmoidal arteries, laterally by the superior orbital fissure. Anterior ethmoidal artery medially, laterally the meningoorbital band. We can cut the meningoorbital band because it's no nervous part of the superior orbital fissure with the recurrent meningeal artery here that can be sacrificed, and we can drill out the anterior cranial fossa and expose the anterior cranial fossa dura. Here the optic nerve, we drill out the lesser wing. This is just some drilling of the anterior cranial process and the superior orbital fissure. The transcaruncular incision will allow us to follow this medial corridor, limited superiorly by ethmoidal arteries, inferiorly by the inferior limit of the lamina papyracea. So I perform this very simple surgical corridor that we can use generally for intraconal lesion, but what we can really do is really expose this medial quadrant with here the anterior ethmoidal artery, posterior ethmoidal artery, here the lamina papyracea, here I dissected also the lamina papyracea, and we can assess the ethmoidal mucosa. The inferior conjunctival incision, just to follow this inferior quadrant, limited laterally by the inferior orbital fissure, medially by the inferior limit of the lamina papyracea. Again, the inferior orbital rim, you follow this corridor. This is the infraorbital canal, inferior orbital fissure. I found also this nerve, that is the zygomatic nerve, that is bringing postganglial parasympathetic branches to the lacrimal gland, and this the only main nerve that you can find passing through the inferior orbital fissure, and you can dissect the maxillary roof, and you can identify also all the structure like infraorbital nerve and infraorbital artery. Lateral canthal incision with this lateral corridor, and we can follow this corridor as we have done previously, identify the lateral orbital rim. But what is really important for neurosurgeon and for also ENTs, as for the orbit, as a surgical corridor, the superior eyelid approach with an eyelid incision, generally there is the possibility of perform this lateral canthal incision following the skin fold, so it's very aesthetic. And also, as been described, there is also this eyebrow incision that can be performed. This is generally performed for the intracranial counterpart of this approach, so the supraorbital approach. Always keep in mind, as we have seen before, do not extend it too medially in order to avoid to damage the supraorbital nerve, and do not extend too laterally in order to avoid to damage the frontal branch of the zygomatic division of the facial nerve. So, we are following this corridor that we have seen. We have this setting now. This is the frontozygomatic suture, facies orbitalis of the zygomatic nerve, facies orbitalis of the greater wing of the zygomatic bone, facies orbitalis of the greater wing. We are following this corridor, so let's think about the anatomy that we have seen before from an extracranial point of view. This is the meningoorbital band, this is the zygomatic nerve that we have seen before. This is what we are expecting. So we are expecting here the greater wing, dividing us the temporal fossa, so two windows, one window that is an extracranial window, one window that is an intracranial window that we can assess from the lateral wall of the orbit. And so this is the corresponding view. Temporal muscle, middle cranial fossa dura. Let's concentrate on this window, and what I told you before, what is limiting your access, your extradural dissection and assessing the middle cranial fossa in its more medial portion, the sagittal crest. So now you can see, and you will see, if you remove this piece of bone, you can literally have a window that is directed to the cavernous sinus. So by removing this little piece of bone, that is the much more medial portion of the greater wing, you can assess the cavernous sinus, start to perform the peeling of the lateral wall of the cavernous sinus, and perform the interdural dissection.
Can I say something about
Please, go ahead.
You see now another starting point to enter the cavernous sinus, because until now we say that the meningoorbital band is the starting point to enter the cavernous sinus.
Yep.
But as you know, any interdural dissection can be done in any foramen over the middle skull base. This is foramen rotundum with V2 entering inside.
Foramen rotundum here.
At that level, you also will see that the periosteal layer and the meningeal layer that is above the nerve, that is covering the nerve, as you can see there, are splitting. So this split is not only at the level of the meningoorbital band, but also at the level of the foramen rotundum.
Yep.
And when I say the meningoorbital band, I mean that the other foramen in which we have this splitting is the superior orbital fissure. So the superior orbital fissure and V2 are the two points in which you can split the meningoorbital. Now he's starting from below. He can do it. But until now we say no. Cut the meningoorbital band and starting there. But you can start also here, over V2.
Yeah.
Thank you.
Question. Can I have a question?
Yep.
So, to make it clear, so now we are facing.
Sorry, but I have the sound of. Can you?
Okay, so now we are facing the maxillary structure.
Yeah.
So that one from the sagittal crest and then go below.
Yep.
From the tubular.
Yep.
And then
Yeah.
there is the
Yeah. Yeah.
You need to remove it.
You can perform this dissection if you want. You can enlarge, but you don't need to remove to open the window to assess the cavernous sinus. You don't need to. As Dr. De Notari said before, the real structure that is closing you the access to the cavernous sinus is the sagittal crest. And I tried to show you in an extracranial view before, and now from another perspective that is direct. So,
I also have a question. If you were cutting medical part, how to cut it not to damage nerves?
The nerve.
Nerves, yeah. Which are
Nerves in the superior orbital fissure, you mean?
yeah, so
How to cut, what to take,
so
laterally, medially, how-
I was doing a dissection before with two doctors there, and what I said them is if you would like to be very safe, identify the meningo-orbital band, is you have to come from anterior cranial fossa and go from above to below, because this will be the impediment. They will not allow you to go. If you go from the lateral wall, you risk to proceed and go inside the superior orbital fissure. But if you come from above and you stretch down, you will have for sure the meningo-orbital band that is creating you an impediment. And so you can go, if you go like much more posteriorly, you can go from posterior to anterior, arrive to the edge, and this will be the meningo-orbital band. The meningo-orbital band, for definition, is a anervous part of the superior orbital fissure. There is the meningo-orbital band, so I dissected before in a superior eyelid, a poor superior eyelid corridor, but I can show you before.
And getting this idea that it is a nervous part.
Yeah, so the meningo-orbital band was here. I opened it before.
This is recurrent major artery.
Yeah.
Next. Yeah, here.
This one.
Maybe this is manual
Yeah.
band, but this is the clinoid process. If you use cut manual band, there is a clinoid process behind manual band. If you enter this side, it's very dangerous. But
Yeah,
you can have a
exactly.
clinoid process. Just only one. If you want, you can use the monopolar
Scissors or
process.
scalpel?
Yeah.
You do it with scissors or scalpel?
Scissors, what if you want, you can use the scalpel. It's my junior faculty used monopolar fertilization because he perforated one space.
Yeah.
So
Exactly. So, as Dr. Dossi-Kong said, so the concept that I was telling you is coming from above, and then you stretch it down. So you can also move a little bit laterally. This is V3, this is foramen ovale, this is middle meningeal artery with foramen spinosum. But if you proceed peeling the lateral wall of the cavernous sinus, performing this interdural dissection, this is the view that you are going to have. So from up to down, from medial to lateral, oculomotor nerve, trochlear nerve, V1, V2, V3, JSPN, foramen ovale, foramen rotundum, and here the superior orbital fissure. And also you can identify, if you elevate V1, you can identify the abducens nerve that is closing, that is very closer to the horizontal tract of the cavernous ICA. So I think that this is the most important slide, because allow us to understand what is the goal for an endoscopic transorbital approach that is directed to the middle cranial fossa. When you are arrived to the cavernous sinus, this is your target, but this is not your final goal. Because what we have said in the first two slides, that the endoscopic transorbital route is used as a corridor for several intra and extracranial regions. And so this is very clear. So this is an endoscopic transorbital route. This is an endoscopic endonasal route through a transpterygoid approach from door to Meckel's cave, and this is an OSI approach with some other dissection. So if we follow the triangles of the middle cranial fossa, we can correlate which are the corridors that you can follow in an endoscopic transorbital trajectory and which are the structures that you can expose. So for example, here, the supratrochlear triangle, we can assess here the ambient system. Infratrochlear triangle, Parkinson triangle, we can assess the interpeduncular system. Here, the Dolenz triangle, clinoidal triangle, the optic carotid region. Here again, the Mullen triangle, so the anteromedial triangle, you can assess the sphenoid sinus, you can see here. So here, the anterolateral triangle, you can directly have access to the Eustachian tube, to the pterygoid process. Here, the posterolateral triangle, the Glasgow, you can assess. Here, you can see the infratemporal fossa. Infratemporal fossa if you drill here. And here, the Cavase triangle or posteromedial triangle that will allow you to assess the posterior cranial fossa. So your last step of this section will be this. So this is a magnification of the posterolateral triangle. The Cavase triangle is not really a triangle, but in my opinion is a trapezoidal shaped area that is limited anterolaterally by JSPN and the projection of the horizontal tract of the petrous ICA, laterally by the projection of geniculate ganglion and cochlea, posteriorly by the anterior projection of the ICA, medially by the petrous ridge, and here anteromedially by the lateral limit of V3. If we drill out this area, so we can directly assess the posterior cranial fossa. If we would like just to close our dissection, perform a... Okay, so just the last slide, the lateral orbitotomy is the same corridor that we have seen. We just drill out much more the remaining portion of the greater wing, some of the temporal squama, and we have this extradural corridor that can be expanded laterally, and we can expose substantially all the anterior surface of the petrous ICA, of the petrous bone. Thank you.
Thank you, Eduardo, for this outstanding presentation. The last presentation is very connected to this one. Dr. Sergio Corbino is going to show us this kind of surgical nuance. We can say that is the lateral orbitotomy done open door. It means that you will explain better, but as we told you before, it means that you perform a kind of lateral orbitotomy, leaving the bone intact attached to the temporal muscle and just abstraction. But he will show you this technique, because it could be a very good technique to start. Then we will go, I think that we will go to lunch.
Okay. Good morning. Thank you, Matteo, for the invitation. Thank you for coming. I'm going to speak about the role of the lateral orbital rim removal during transorbital approach. So, as you know, endoscopic transorbital approach to the middle fossa present peculiar advantages like its minimally invasive nature, minimal or no brain retraction, no crossing plane of cranial nerve and major vessels, short distance to the target, straight corridor to the target, and small bony defect, which allow to treat the pathologies affecting paramedian aspect of anterior middle cranial fossa up to the petrous apex. Nevertheless, its main drawback is its narrow surgical entry area, which is bounded by the vulnerable content of the orbit medially and the unexpandable bony tissue of the superior, inferior, and lateral orbital rim, which naturally limit the surgical freedom, the exposure working areas, and the angles of attack. So to overcome these limits, we have two strategies. The first one is the use of the exoscope, which avoid the encumbrance of the endoscope inside the surgical field at the beginning of the surgical procedure. And the second one is to enlarge, to expand the lateral working corridor through the lateral orbital rim displacement. So since the first description of the technique by Kronlein at the end of the 19th century, many variations of the technique have been described. Here we focused on the role of the lateral orbital rim during the endoscopic transorbital approach. Also here there are different techniques. Some authors consider to add the superior and lateral orbital rim to the standard transorbital approach. Others consider just the lateral orbital rim. We suggest to proceed in a graded manner, so in a stepwise approach, from the standard to the real complete lateral orbital rim removal by harvesting an osteopericranial flap based on the overlying pericranium in a hinge or floating orbitotomy involving the lateral orbital rim straddling the frontozygomatic suture. In this way, you can proceed in a graded manner. So during the procedure, you can choose to proceed and go forward directly to a complete removal, just dissecting the pericranium. But you can tailor your approach according to the patient, the pathology features, according to the goal of the surgery. So these are the common steps during the standard superior eyelid transorbital approach. So we identify the superior eyelid, perform superior eyelid skin incision, identification of frontozygomatic suture, subperiosteal periorbital dissection. We identify the main anatomical landmark IOF and SOF, drilling the lateral orbital wall with exposure or temporal lobe dura mater, sagittal crest removal, and meaning orbital band exposure. Finally, the interperiosteal dural dissection of the lateral wall of cavernous sinus. These are the maneuvers to convert the standard into the open door or extended approach. This is the bony anatomy of the orbit. This is the lateral orbital wall drilling during the standard or conventional superior eyelid transorbital approach. We suggest to, as a first step, to extend the drilling more anterior on the intraorbital surface of the zygomatic bone. Finally, to add 2 bony cuts. The first one above the frontozygomatic suture, the second one at the junction between the body of the zygomatic bone and the base of the frontal process of the zygomatic bone. This is the representation. This is the specimen, cadaveric specimen dissection. So we suggest, in this way, we start with the open door without a standard approach. So firstly, you perform a shallow groove in a vertical plane in the intraorbital surface of the zygomatic bone, in a vertical plane from a superior point just above the frontozygomatic suture, in an imaginary horizontal line from the superior orbital fissure going proximally, anteriorly, direct to the frontozygomatic suture, and going down up to the inferior orbital fissure. Then we make 2 cuts. The first cut is above the frontozygomatic suture across the lateral orbital rim, and the second one is inferiorly from the anterior end of the inferior orbital fissure to the base of the frontal process of the zygomatic bone. Finally, we can detach the osteopericranial flap laterally, but leaving it in situ, in a floating way, in an hinge orbitotomy, attached to the overlying pericranium. This is in a real patient, and this is the video. First, we perform you can use the drill, the piezoelectric device, the craniotomy without footplate, whatever you want. This is the first cut with the piezoelectric device above the frontozygomatic suture, connecting the first shallow groove performed before. You leave a shallow bone, thin shallow bone, to protect the deep surface of the temporalis muscle and fascia. This is the inferior cut. And finally, you detach. You can fracture. In this way, you can leave it in situ. In a dynamic or static way, you can retract it laterally, and you increase your axial angle of attack. This is a study demonstrated that you can increase your axial angle of attack. We have the 4 targets. The first one is the anterior clinoid process tip. The other ones are foramen rotundum, foramen ovale, in trigeminal impression, and we demonstrated an increase of the gain angle of attack. This is the comparison with the standard transorbital approach with the standard lateral orbitotomy, and we demonstrate a lot of advantages in terms of surgical procedure, in terms of functional and aesthetic outcome. And these are 2 other studies performed before. One used superior and lateral orbitotomy add to the standard transorbital approach with main pro and cons. So finally, we demonstrate that adding the lateral orbitotomy provide several advantages in terms of surgery, in terms of functional and aesthetic outcome, and we suggest you to proceed, as told before, in a stepwise approach, in a graded manner. Because in this way, you are minimally invasive, and you can tailor, you can customize your approach according to target, according to the goal of the surgery, according to the pathologies, the patient features. Thank you.
Thank you, Sergio. So now the question, doubt. Yeah, truly you can have two ways. You can fix with titanium plates, but as you know, the skin here is very, very thin. So using the piezo with very small cuts, you can even perform 2 holes and suture, which is advisable if you have the possibility to use the piezo surgery, because this way the patient will not complain. Nothing happens if you put, as Professor Chris Moore showed yesterday, you can put pre-plate. Professor Agonetta always told me, we have to pre-plate, not to do it after. Pre-plate before doing, and nothing happens. But if you want, you can also suture, no problem.
Photo group, guys.
Yes,
Before
but we
lunch.
have to take out the lab
As you want.
because after they have the lunch, no?
After we have the lunch.
And they have to take out the.
So we take a big picture all together on the terrace of this course. You are encouraged to change your clothes if you want to. And we saw you in 5 minutes downstairs on the terrace.
Where is
okay?
the lunch? Where is the lunch?
Where the lunch
But
will be
you
delivered.
try to save